Hi, good evening, colleagues, and thank you for giving me the opportunity to share my advice on how I manage atopic dermatitis in my practice. I'm going to start off with a patient case, an 18-year-old male. This patient typically has seen numerous GPs, dermatologists, and been on lots of treatment before. He has extensive eczema. And remember, the redness is usually not easily seen on pigmented skin. He has keloids from previous acne and also severe atopic eczema. Here you can see these numerous plaques of eczema and appreciate the erythema in the facial area. On the back of the scalp and the trunk, you can see that almost the whole of the body is affected. He has to cut his hair short just to help with the scratch and the itch. There are bruising and some striae occurring due to the long-term steroid use. Multiple scratch marks as shown at the back of the legs. Basically, you can see the effect that his eczema has on his quality of life. Atopic dermatitis, or AD, is a chronic systemic immune-mediated type 2 inflammatory disease, which is characterized by intense pruritus and recurrent eczematous lesions in patients. Patients with AD experience a multidimensional disease burdens of signs, symptoms, and quality of life. And the burden of AD increases with greater disease severity, which makes sense, and in patients with coexisting type 2 inflammatory illnesses. Patients may experience impaired QOL, which then impacts their daily activities, their productivity, loss of work at school, and sleep disturbances. Patients may experience mental health disorders, including anxiety, depression, suicidality. In addition to chronic disease signs and symptoms, patients may have disease exacerbations, which amplify a lack of disease control and constitute a continuous burden on physicians, patients, and caregivers. Type 2 inflammation is a key driver of the epithelial barrier dysfunction, which can then result in the formation of lesions, pruritus, and bacterial colonization, which leads to infection. Skin infections and other serious infections are common in patients with AD and can result in hospitalization. Patients with AD also have comorbidities, including other type 2 inflammatory diseases and bone health related issues as well. Now, AD is common. It affects approximately 4 to 5% of the worldwide population. It is something we see every day in our practice, whether it's in GP or dermatologist outpatient clinics. We need to have a simple, practical approach to managing these cases. You can see in the EU, prevalence is 4.4% of their population. Fortunately, half of these cases are mild. In South Africa, there aren't too many studies addressing the prevalence, but the phase 1 ISAAC study showed an 8.3 prevalence in 1 year in the children in Cape Town, aged 13 to 14, with 2.3% of them having sleep problems for more than one night a year. The phase 2 study showed an increase in prevalence with 13.3% of children affected by this condition. Now, we all know that the lifetime prevalence of developing this condition is 15 to 30% in children, 2 to 10% in adults, and the incidence has increased 2 to 3 times since the 1970s. Now, the etiology is multifactorial. A host of factors, including genetics, environmental, immune, and microbiome changes, have all been proven to play a role in barrier dysfunction. Now I'm going to try and simplify this dysfunction of the barrier that we keep harping on when discussing AD. We often use a brick wall model of the skin barrier to explain this to patients. Skin cells are analogous to the bricks, And the lipid layers are analogous to the cement. In tall brick walls, iron pods are passed down through holes in the bricks to give the walls greater strength. And these iron rods are analogous to the corneodesmosomes that lock the skin together. Now, in normal skin, the corneodesmosomes are strong throughout the stratum corneum. At the surface of the skin, the corneodesmosomes start to break down as part of the normal process of shedding of the scales. Individuals with atopic dermatitis have an abnormal barrier, which results in breakdown of the skin and an increased loss of water from the skin. This allows not only the loss of water, but also the penetration of irritants and allergens that may result in inflammation. When allergens and irritants reach the systemic circulation, they are not presented to the immune system in the usual way. And this can lead to the loss of normal mechanisms to allergens, resulting in sensitization and then inflammation. This immune response is known as the Th2 pathway, whereby dendritic cells are activated, releasing interleukin-4, which then snowballs this inflammation in the skin, releasing cytokines interleukin-4 and 13, which is responsible for type 2 inflammation. Now, this is important, as you will see later on regarding our newer treatments, which are targeted at these interleukins. In our pediatric population, the onset of AD is typically before the age of 5, but usually before the age of 2, actually. And the risk factors for persistent in adulthood is onset of AD later than 2 years of age, those of the greatest severity of AD which persists for more than 5 years into adulthood, and a family history of atopy. When we talk of outgrowing this disease, we know that 80% of childhood AD will not persist 8 years after the diagnosis, and less than 5% will persist 20 years after the diagnosis. However, when analyzing 7,157 patients from the pediatric US registry, it was shown that more than 80% of participants had symptoms or were using their medication to treat AD by the age of 26. AD lesions are heterogeneous, which means they can appear from simple erythema and almost impossible to see in darker skin, and then lead to extensive oozing, thrusting, lichenification. The morphology and distribution of these lesions also depends on the age of the patient. Infants typically affect the face and extensor surfaces, as shown here. From 1 to 2 years onwards, the flexural areas are typically involved. And in adolescence, the flexures, the wrists, ankles, eyelids, and scalp are mostly involved. Again, this condition can affect any age group, and the distribution and severity depend on several factors, age being the biggest one. The disease activity can vary tremendously, and flares don't always occur with seasonal changes. The severity will impact sleep and the quality of life. The diagnosis, according to the South African guidelines, which was recently updated, is that AD is a clinical diagnosis. No routine allergy or blood tests are recommended. I repeat, no allergy testing is required and a waste of the patient's funds. So please don't do this. We see it in everyday practice. Patients come with a host of blood tests being done, and the medical funds are depleted in most cases. Now, itchiness or pruritus is the hallmark of the disease. So it's a major criteria. You have to have pruritus, otherwise you can't make the diagnosis. And then you need 3 of the following in addition to pruritus: history of flexural dermatitis, visible flexural dermatitis, history of generally dry skin in the past year, a personal history of asthma or hay fever, or a history of atopic disease in a first degree relative in children which are under 4. And an onset under 2 years of age. And this is again only used for children which are aged 4 years or more at the time of diagnosis. So as we said, these are the hallmarks of the diagnosis. These are some examples of our kids with severe atopic dermatitis, which we see in our derm clinics every day. We can feel the pain in these patients. Denny Morgan lines or folds, we can see it's this extra line under the eye, and that often denotes allergies in families. Sometimes it's inherited and not always related to it, but in most cases, it's a sign if we're not sure of the diagnosis. Hyperlinear palms, which are seen in some of our celebrities as well, is often a sign of allergies in the family. This is an example of KP, keratosis pilaris, which are usually increased in our eczema population. Pityriasis alba appearing on the face in our patients with eczema is often due to exposure to the sun. Scales are a common way to quantify the severity of a number of diseases in clinical trials. They're not always routinely used in clinical practice because of the time. But in AD, 3 scales are most commonly used in clinical trials: the SCORAT, the EASY score, and the IGA. It's now much quicker and easier. I have an app for it, and it's quick to do. Most of the medical funders do want you to use it if you can apply for the more costly medication. Now, looking at the impact of AD, as we said earlier, it can affect almost any part of the body at any time of life. It is important to note that skin conditions are the 4th leading cause of non-fatal disease burden across the globe from all conditions in the world. And this graph shows the average amount of years lost due to disability of a medical condition across 187 countries in the world from 1990 to 2010, the 4th leading cause. AD is the 2nd leading cause of global burden of disease for subcutaneous conditions, which is second only to skin cancer. Amongst kids, AD had the 2nd largest impact on QOL, following only cerebral palsy amongst all the chronic disease studies. These are not small studies. The impact of this condition on our kids is vast and devastating. Symptoms such as itch, sleep disturbance, increase in asthma, skin infections, immune-mediated disease, mental health disorders, and work productivity, just to name a few. The list goes on. Not only that, higher AD severity is associated with an increase in type 2 inflammatory disease in adults such as allergic rhinitis, asthma, rhinosinusitis, esophagitis, nasal polyps, autoimmune disorders were all increased in this population. In children, scratching and impaired sleep had the highest impact on quality of life. And as the AD became more severe, so did the QOL decline, which stands to reason. 68% of adults didn't feel alert on waking, didn't feel refreshed in the mornings, were unsatisfied with their sleep. And half of adults with AD felt tired throughout the day, every day. The parents reported that their own sleep was affected when their kids were scratching through the night or kept up. Up to 39% of kids with AD had been bullied because of their skin condition. 20% of kids missed school due to their skin condition, and 12% of them missed more than 20 days of school per year just because of the eczema. During a year period, the average days lost by adults in adults were over 10. We know the risk of depression and suicide amongst adults with AD are much higher than the general population. 1 in 4 had depressive symptoms, and as much as 1 in 8 had suicidal ideations purely due to their skin condition. Not forgetting the financial burden of the disease. The annual costs in Netherlands, they were calculated to be on average of more than 15 to 20,000 euros per person per year. 15 to 20,000 in euros per person per year. Adults with AD have a higher comorbid type 2 inflammation, as we said earlier, with the atopic march. On average, the number of infections increased by 1 to 2 per year. There are some examples of impetigo from staph and HSV, ear peticum. So what is the holy grail of treatment? We need to balance efficacy versus our side effects and cost. And that is where the unmet need lies with current available treatments. The treatment options start off with avoiding irritants, avoid soaps, shower gels, bubble baths. Use simple emollients to wash, fragrance-free. Emollients must be regularly applied when atopic dermatitis control is good. And for more active disease, use the ointment formulation. Treat the inflammation which is causing the itch. Topical corticosteroids, topical calcineurin inhibitors. Then go on to phototherapy and systemic immune suppression in step 2 if all topical treatments fail. Our systemic options are methotrexate, cyclosporin, azathioprine, mycophenolate. And then step 3 is if classical immunosuppression treatment fails, you can go on to the biologics. And there's also the Janus kinase inhibitors, which are now being shown to work well. Newer drugs, such as a PDE4 inhibitors, have been used, and we've been using it for the last year or so. The added advantage is they don't give you any skin thinning or striae that you normally get with the topical steroids, but they're used for maintenance and not for active treatment. Remember, we need to treat early to avoid the comorbidities. And there are many, as shown in the slide: cardiovascular, bowel disease, respiratory illness, autoimmune illnesses, SLE, malignancies such as lymphoma, ocular complications such as keratoconus, glaucoma, cataracts, blepharitis, metabolic syndromes such as type 2 diabetes, obesity, hypertension. And in the skin effects, you can get vitiligo, alopecia areata, and cutaneous infections. They all increase in the AD population. So my approach is as follows. We all know that our topical treatment is not the only option for patients. Number one, we need to make sure the diagnosis is correct. In adults, mycosis fungoides, pityriasis rubra pilaris, drug reactions, all can look like atopic dermatitis. So if you get an adult who has intractable atopic dermatitis, always do a biopsy, and do a biopsy every year on these patients. In kids, infections can present like that. You can get reactions to products or contact dermatitis. Remember to check the diagnostic criteria that the patient fits into atopic dermatitis. Early onset when young, we associated with atopy, flexural areas, etc., as we said, and make sure you tick off all the correct criteria. The next step, educate your patient about his treatment, how to use it, strengths to use. Support groups are so important. We've got a Facebook group that was started, the atopic dermatitis group, and it's of so much help to our patients. Bleach baths, wet traps, address steroid phobia, and so forth. Then step 3 is to optimize the treatments, especially our topical treatments. We find that most often the topical treatments aren't optimized or given in the correct way. So make sure the type of moisturizers patients using is correct, current topical steroids and concentrations and the mixtures are correct. Use the right vehicle. For your sensitive area, you're going to use a cream. You're not going to use an ointment. Use products that patients are happy to use, such as in their face, they don't like to use ointments. So make sure you have the correct diagnosis, you educate the patient, and then you optimize your topical treatments. And this is exactly what the International Eczema Council expert panel advised. The first thing they do is have you excluded an alternative diagnosis. Then, as I said, make sure they know about avoiding your triggers, irritants, and stressing the burdens of adherence to medication. And the third step is to optimize your intensified, your topical treatment for an adequate amount of time with your wet traps, etc., which are not often used. And this I do within the first 4 weeks. And then if still not under control, we can think of going for phototherapy. We know it doesn't work for everyone. So if that's not an option in combination, then I start the patient on their systemic treatments immediately. The choice is yours depending on pregnancy planning, renal function, diabetes, alcohol use, age, etc. So when is it appropriate to step up your therapy? It's exactly when you fulfill these 3 steps and your patients are still not under control. So how do I approach this? I try to understand where are we now? How severe is a patient? An objective and a subjective approach. A score may be where I can follow up the patient if the patient's improving substantially, and then a subjective from the patient. How are they feeling about their skin and their overall health? Then I decide with the patients the goal of treatment. Where do we want to go? Then we walk the way, go stepwise to move the patient where we are now to where we want to end up, but realistically. So how do we determine where are we now? Again, try and keep it simple. And to use an objective scoring, the Physician Global Assessment score is probably the easiest. 0 is clear, and 4 is severe, and everything in between is there. This is easy. You can do it very quickly. So in my patient, I would mark that patient as severe, then I multiply by the body surface area. That gives me the Physician Global Assessment times the body surface area. So that's 4 times 70% in my patient. 280, I write that in the file. I can then objectively assess the patient whenever they come. Are they improving or not? Because it's very difficult if you're seeing patients all the time, every day, and only every few months. How do you remember how they looked before? I take lots of pictures and photos in my practice. I have a machine that does a full body scan, but even if you don't, put a score in, and it's easy to follow these patients. You can also do the easy score, but for me and all of us, it takes time. So what correlates easily in my mind is this score, and it correlates to the easy score. The easy score is often used for the funders. And then I try to find out what is the patient symptoms that they have. The pruritus visual analog scale is quite nice and easy. The patients just draw a circle around where they think they are on that day. And in the follow-ups, I want to see if the itchiness is getting better, because sometimes the skin looks better, but the patient is still struggling, or vice versa. And again, tailor-make it to your patient. So if your patient is still struggling with the itch and still struggling with his DLQI, quality of life, you know that's going to affect him more, even if the skin is looking like it's improved. I then ask for a DLQI, which we can use for applications to medical funders, and I follow up the patients for his daily living scores. There's a nice tool for following up patients, the atopic dermatitis control tool. You ask 6 easy questions. They can fill it in the waiting room before they see you. And this gives you a nice overall assessment and involves the patient in the consult. So they feel like they've been given a lot more than just a quick 20-minute one-sided consult where you're speaking to them only. And if the patient is not under control, you can quickly step up your therapy. Right, so now we have determined where we are. And we determine where we want to go. And we are going to walk this way together with our patient. To recap, we use a Physician Global Assessment score, and the easy score and the visual analog score, DLQI, to determine where we are. And while the patient is walking on this way to control, you can then use the atopic dermatitis control tool to see how they are doing. So how do we again determine now where do we want to go? Now that's a little more difficult. But the idea is we want to hydrate and restore the barrier, reduce the inflammation, and control the symptoms better. These are probably most important, but you can also think of you needing to maximize the quality of life symptoms in each, reduce the steroids, flares, secondary complication, and others. So we need to sit with our patients and discuss what they want most, and then almost focus on our treatment on those specific goals that they are discussing. Much like we do in aesthetics, it's important to address the patient's main issue, and then you offer them other treatment options which will give them an overall better result. If you want to make it really objective, we can look at the Holy Grail, which is a score rating like the Easy 90, which is 90% improvement, or a numerical scale of 0 to 1, which is for pruritus, or DLQI less than 5. And then you want to minimize the side effects. Unfortunately, there's still an unmet need in AD, but we are moving closer and closer with drugs. And then we need to share the decision-making with our patient. And what this means is we lay down all the options, the pros and the cons, and we ask the patient where they want to go. So they are part of the decision-making process. Always involve your patients in it. There's so many things that goes through our mind, and we sometimes assume things that are not there. What the patient can afford, cannot afford, where the patient stays, what the patient can do, the support system. So involve your patients in the decision-making. Also, a very practical way to tell patients is where we want to go is to say, in 3 months, we want them to be at least 50% better. And in 6 months, at least 75% better. So I say to the patients, it's easy to get there. We want you to be 50% better in 3 months, 75% better in 6 months. And they're quite happy to go on this trip with us and walk this way. So if we use the physician global assessment, we want to at least go from severe to moderate and then mild, and at least mild if you're not getting to clear skin. So to summarize, what I want to show you, when you see the patient, what looks like moderate to severe eczema, make sure you confirm the diagnosis, make sure you educate them adequately, make sure you optimize the topical therapies, even if you think about only going for phototherapy. Then you move on to your systemic treatments. In summary, you use the scoring tools to decide where we are now, and then you use conventional systemic treatments. And now the new advanced therapies, we get the patient to where we want to go. And if we can get happy patients who want to celebrate their lives, we should, however, constantly evaluate the response so we can get the results we want and not be complacent. The worst things when our patients, they change from doctor to doctor, and they don't understand the journey we're going to get them to this happy place. In general, as we said, patient education, skincare, emollients, you got to use as frequently as possible. It's not always easy to use more than once or twice a day. And correct bathing techniques, avoidance of soap products, avoidance of triggers that irritate the skin, extremes of temperature, etc. Viral infections are difficult to avoid, but they can exacerbate. Psychological interventions, important to get their stress and anxiety under control. Treatment should start as early as possible, as soon as possible with the first signs of eczema. You want to break that itch-scratch cycle. Moisturizers remain the cornerstone of AD treatment and the single most important non-pharmacological therapeutic option. The choice of emollient depends on so many factors. One of the biggest factors is the age. Different formulations can also be used for different anatomical locations. The patient's preference may change over time. The younger patients can be fine with using a thicker product. Teenagers don't want thick and pasty products. So does adults and men. So important to look at your patient individually. Avoid overheating. In winter, don't use these thick woolen clothing, flannel products. Duvets, yes. Blankets, no. Avoid your animals being on the bed. Cigarette smoke is a definite no. Food stuff that irritate the skin, rough textiles, remove labels from your clothing. Wear loose-fitting clothing and keep the skin closed and covered to prevent environmental effects on it and hot in areas. Keep your fingernails short so you're not scratching and damaging the skin. And avoid skincare products that contain perfumes and colorants. The bath rules is you bath only once a day. And that's important to tell our patients. Short bath, in and out, once a day, lukewarm water, not too hot. Use a moisturizing cleanser. No soaps that foam up too much. Do not shampoo the hair in the bath because shampoo can irritate the skin. Bubble baths, we know, definitely not. Pat dry with a soft towel. Don't wipe until that skin is too dry. And apply your emollients on wet skin. That traps the moisture in the skin and really makes such a big difference. Bleach baths I use extensively in my practice, and this is just an easy way to do it. You add bleach to the water. For a full tub, it's about half a cup of bleach. For half a tub, about 1/4 cup. And you soak for at least 9 minutes or 10 minutes at most. We try to keep it short, and you only rinse your skin if it's irritated. You don't need to rinse the bleach off it. pat dry gently, apply topical medications to your affected areas, and emollients to the entire body. Remember the sensitive areas under the armpits, in the groin area, under the inframammary area. You've got to use creams and not ointment. Our consensus statement looked at moderate to severe disease, looking at our targeted treatment. Of course, I'm a little biased considering I'm on this article, but this is a comprehensive guideline in managing our patients with this condition. This is where we concentrated in the consensus, in the systemic area. This algorithm was created making emollient standard therapy, and if the skin fails to improve after 4 to 8 weeks, then you move on to your systemic treatments. Don't wait too long. Patients do become stressed when mentioning our systemic medication, but as doctors, we need to offer that early to break the cycle. So don't be too stressed to start your systemic treatment early. Stop this condition from becoming a habit. We give these meds for 8 to 12 weeks, and then we normally decide to step up. Biologics are unfortunately not first-line therapy in South Africa because of the cost. But then again, most countries in the world these days have financial constraints. And even first world countries where you think it's actually easy to get these drugs are not. So we need to give it time. Have a detailed history and take pictures of your patients. Always send to the funders to motivate if needed. We need to show how this condition affects our patients. So what's new in atopic dermatitis? Our traditional immunosuppressants such as methotrexate, cyclosporins have a broad inhibitory action but are not recommended for long-term use. Newer generation systemic suppressants such as Janus kinase inhibitors inhibit multiple pathways. Long-term studies are still ongoing. There are black box warnings, and then laboratory testing and monitoring is mandatory. They are now newer biologics and are targeted to inhibit specific mediators in tackle inflammation. And some of them don't even require any laboratory testing. Interleukin-4 and 13 have unique and overlapping roles in tackling inflammation and the pathophysiology of AD. Interleukin-4 is uniquely responsible for the differentiation of naive T cells to Th2 cells and has roles in beta cell activation, interleukin-31 production, and expression of the interleukin-31 receptor. Interleukin-4 and 13 both contribute to changes in gene and protein expression, leading to Staph aureus, colonization, immune cell recruitment, pruritus, and barrier disruption. At the epidermal barrier, interleukin-4 and 13 contribute to multiple mechanisms that disrupt the barrier integrity. And these cytokines can impact sweat gland function, epidermal protease expression, our microbial dysbiosis, lipid metabolism, and expression of our structural proteins, which are now so important in keeping the skin barrier together. Results from our clinical trials and real-world studies in patients with AD demonstrate improvements across the multidimensional disease burden of AD when patients receive interleukin-4 and 13 inhibitors, and patients experience improvement in their signs, symptoms, and quality of life, and they sustained through 4 years of treatment. Patients have fewer flares, reduced need for rescue medication. They actually get off all their topical treatment. Imagine just taking an injection or tablet and not even needing the topical emollients. Fewer Staph aureus infections. And dupilumab also demonstrates the ability to improve the barrier function alone. Regards to the efficacy, the DLQ scores improve from baseline to week 16 and 52 with dupilumab plus topical steroid versus placebo topical steroids in adults in the Corona study. In dupilumab treatment resulted in clinical meaningful and sustained long-term improvement in quality of life in patients aged just from 6 to 11 in 12-7 in the ongoing pediatrics study, the OLE study. And this was through week 52. The objective of the study was to evaluate real-world data on the efficacy and safety of dupilumab in AD. PubMed and Embase was searched for observational studies with data on efficacy, drug survival, and safety of dupilumab for the treatment of AD. One of the primary outcomes was mean percentage change in EASI scores. 22 unique studies encompassing 3,303 AD patients were included. 20 studies examined the adults, one examined adults and children, one study examined children only. In most studies, patients received dupilumab 600 milligrams as a loading dose, followed by 300 milligrams every 2 weeks. Concomitant topical steroids were allowed in 10 studies. The weighted mean reduction in EASI score was 54% improvement after 4 weeks. 54%, 71.9% improvement after 12 weeks. And further 69.9% improvement after 16 weeks. One study reported a mean reduction in EASI score of 79% after 6 months of treatment, while another study reported a reduction of 95.5% of patients after 52 weeks. 95.5% improvement in their skin, which was maintained through 52 weeks. So the efficacy of dupilumab treatment in AD patients was overall consistent with the results of the clinical trials. A total of 61 patients, 16 children and 45 adolescents with moderate to severe AD were treated with the interleukin inhibitors between March 20 and 2022. All effectiveness outcomes showed a significant improvement during 28 weeks of dupilumab treatment. The mean EASI score changed from 20.2 to 6.4, and the mean NRS, pruritus, and POEM significantly changed from 6.4 to 3.5, and from 19.5 to just 9.6 respectively. The proportion of patients achieving at least one absolute cutoff score indicating control disease after 28 weeks of dupilumab treatment was 86.9%. So 86.9% of patients got clear skin after 28 weeks of treatment. There was no significant difference between week 16 and 28 for all the outcomes. It was possible to discontinue oral immunosuppressive treatment in 75% of patients before their 4-week visit, but all patients stopped their oral systemic immunosuppressant that they were on previously before the 16-week visit. So to conclude, AD is a chronic relapsing disease with a high burden and impact to quality of life for patients and their caregivers, requiring long-term continuous treatment. There is a strong medical need for systemic, effective, and safe treatment that can offer long-term control. Dupilumab targeted the shared receptor subunit for interleukin 4 and 13, the key and central inflammatory cytokine in AD. Interleukin 4 and 13 are the drivers of skin barrier dysfunction in AD, including microbial dysbiosis. Dupilumab demonstrated rapid after first dose and sustained up to 52 weeks in children and 4 years in adult disease control in most patients with moderate to severe AD in signs, symptoms, and quality of life across ages, as well as a prevention of flares. And the incidence of skin infections in patients on this treatment is not associated with an increased rate of serious or herpetic infections. There were no major safety concerns with either short or long-term use in adult and pediatric population. And the great thing about this treatment is it didn't require any monitoring. Upadacitinib is a new inhibitor, Janus kinase inhibitor, which has shown great results in my patients. I think our clinic has one of the biggest population of patients on this drug with really great results. The itch is literally gone in 2 days. Yes, 2 days. And you know that is the one symptom that affects patients the most. That itch. 81% achieved an EASI-75 response on the lower 15 milligrams a day dosage. And over time, the response did not wane as shown here. 60% of patients achieved clear or almost clear skin within 8 weeks of starting this drug. Clear or almost clear skin. These are the events per 100 patient years, the risk of varicella zoster, headache, acne, elevated blood CK, nausea was significant. The increase in patients who were JAK kinase inhibitors compared to the placebo. However, your serious infections like your non-melanoma skin cancers, malignancies, major adverse cardiovascular events, when VTEs, nasopharyngitis was not increased compared to placebo. So to conclude, our JAK inhibitors are generally well tolerated. Some common adverse events differ between the inhibitors, and some adverse events are dose related. The most common adverse events are acne, headaches, non-serious infections such as upper respiratory tract infection and nausea. The long-term safety of JAK inhibitors is generally consistent with those which are seen in the short term. And the rates of your VTE thromboembolism, major adverse cardiovascular events, malignancy, and varicella zoster remain very low over long-term use of this medication. So yes, there is hope for our patients. We just need to treat early, and we need to let them know that there are good treatment options where they can get clear skin. So thank you for affording me this opportunity to talk to you tonight. And let's empower our patients on this journey to clear skin. Thank you.